I'm Dr. Jason Beckta, and this is Out of the Basement, a podcast dedicated to practical radiation medicine. And today we are really leaning into the practical part of this and talking about myths of radiotherapy, specifically the myths that surround using lotion on your skin during a course of treatment. And I think this is one of the oldest sort of myths. And actually, I would argue maybe back in the day, it wasn't so much a myth, but this is something that haunts me to this day, daily, no matter what I do. And it is something that I saw, we talked about briefly on Twitter a couple weeks ago, and it kind of pops up every now and again in various forms and iterations. And so just for the casual listeners, because I'm sure there's a ton of casual listeners to a radiation medicine podcast, I'm certain of it. Bolus in our context of radiation medicine or radiation oncology is any sort of substance that's placed on the surface of the body or the skin that helps pull dose to the surface, deposits dose more evenly. Oftentimes this is done intentionally if you're trying to include the skin as a target, either through the older style superflab or, the floppy gelatin sheets that they keep in the drawers of many departments, or in the modern age of either of 3D printing through something like dot decimal, or I have an in-house sort of system right now called Adaptive from Canada, and actually kind of doing personalized bolus material to the patient's body based on the DICOM data from the CT sim. Bolus was one of the most confusing words to me when I started in radiation oncology or when I was a med student. And I honestly do not remember the first time I was introduced to this word, but I do remember being very confused because I kept hearing the word bolus and there was no IV fluid. We weren't bolusing. I don't know. Up until that point in my life, I'd only heard bolus used in that context. So hopefully I'm not the only one who was confused about that as a student. I don't see anyone admitting that. I'm going to admit it. I was very confused the first time I ever heard bolus. Not even the second time, maybe even the third time. Just like I was very confused the first time I heard about en face electrons. En face is French, which I know now. But that's neither here nor there. So this concept of lotion or cream acting as a bolus material is as old as time, or at least as old as radiotherapy is. And it's something that popped up on Twitter a couple of weeks ago. It pops up a lot in, I'm sure, all of our clinics or in conversations. And it's something that it's really hard for us to shake. And so I was hoping maybe if I throw this out into the digital ether, then we can kind of continue the conversation. And maybe by the end of my career, we won't be talking about this anymore. So where did this all start? And I just, this is one of the few things in my mind where there's a lot of gray areas in medicine. There's a lot of things that could go either way. I think this is pretty sort of set. And if you think that lotion acts as a bolus, you're wrong. Just period. You're wrong. I'm going to go on record for that literally. But if you dig back into seeing the history of this and see where this came from, I think some of the earlier treatment machines before they developed the high-powered linear accelerators that we have today, the first machines were the kilovoltage devices, which really deposit, arguably 100%, but deposit a lot of their energy at the surface of the skin. And in that case, certainly anything on the skin is going to act as a bolus material. And so we're probably talking about, I'd have to go, actually, I know some of the earlier orthovoltage machines were at least in the 1950s, but so at this point, about 70 years ago. And then, so if you pull up, and I will put these slides up on Twitter and Figshare, but in 1992, a paper was published specifically exploring if patients could wash their skin or wash the treated area during treatment. And this was specifically about the breast or chest wall. And so this was 1992. The authors are Campbell and I think it's Illingworth, very British. And so it was in clinical oncology. And it was a randomized control trial. And they literally start with kind of saying just that of some of the desire to restrict washing has come from the time when kilovoltage machines were the only radiotherapy machines available. Severe skin reactions were usual because 100% of the dose was received on the skin. So, and then they go on to say that it's unclear, I'm not sure if it was really unclear, that if this really held true in the megavoltage era. And so they state that the objections to washing were based on two hypotheses. Basically, one, that wetting the skin, the severity of the reaction, and second, that it wasn't the water itself, but more the associated use of soap and the friction caused by washing and drying that damaged the skin. So they did a comparison of I think it was about 100 people, 100 patients, and it was either no washing, washing with just water, or washing with soap and water. And basically, surprise, surprise, showed that the patients who were allowed to wash their skin had better sort of skin reactions, had reduced skin reactions. And so they kind of encouraged that normal washing should be allowed or encouraged, and that it could also aid in the psychological acceptance of the malignancy. Very interesting. I always like reading these papers from not really that long ago, if you think about it, 1992. But so then when they are kind of trying to figure out, like, why would washing the skin help out these reactions? And they state that it's not clear, and that they thought that maybe it would reduce the bacterial numbers that would otherwise potentiate the skin damage from the radiation. And then interestingly, for the purpose of this episode, it may be that a buildup of powder or a desquamated skin increases the dose received by the basal layer of the epithelium by a bolus effect, and washing helps prevent this. So, a little bit of column A, not at all of column. They were really off the mark with that one. But so this kind of really goes to show as early as 1992, or sorry, as late as 1992, this was still being debated. And I think this is important because just medicine is very hierarchical. And so this would have been about the time where a lot of the people who are currently kind of running the show, who are training my generation, the younger generation, were coming of age. So, a lot of the people in their early to mid 60s right now were training and coming out in the late 80s, early 90s. And this was very kind of top of mind. And so this is also the era of Gilbert Fletcher, and where, things like hypofractionation is dangerous to people. There was a very kind of big belief at that time. So a lot of the zeitgeist of the, the culture of the specialty had these sort of beliefs that, things like washing or lotion would have a bolus effect. And it was rooted in the historical sort of accuracy of kilovoltage machines or whatnot. So, this kind of persisted on for quite some time. And I'm not really sure when the first paper, I haven't really dug into that, about when this first kind of was disproved, but in JAMA Oncology, and now, actually, as I'm looking this, I forgot to put the year, but a couple years ago, there's a wonderful paper that came out called Assessing the Validity of Clinician Advice That Patients Avoid the Use of Topical Agents Before Daily Radiotherapy Treatments. And I love this paper so much. So this specifically took 133 patients, and they did dosimetric measurements of different thicknesses of lotions to see if there was an actual effect, or lotions or creams or topical, whatever, agents. And so the take-home message was basically that as long as there's 2 millimeters or less of lotion of a topical agent on a skin, there was no real observable or measurable effect. And I put in the little graphic here, and thinking about these things, and this is how I talk to patients about this, is that 5 millimeters is a pencil eraser. All right, that's pretty, so it's small and big depending on what kind of the context, but so 5 millimeters is a pencil eraser, 1 millimeter is the tip of a pencil, and 2 millimeters is kind of a crayon, the tip of a crayon. So not a perfect sort of real world thing, but it's hard to kind of communicate what that is. But, 2 millimeters of lotion is thick. I don't know, I don't really use lotion that much because I'm not really good at that sort of thing. And even though I'm a do as I say, not as I do kind of doctor, but 2 millimeters is a lot of lotion. And this paper is great. So I would really encourage people to look it up, but they did several different angles, several different types of energies. And they did notice a difference at about 3 millimeters, greater than or equal to 3 millimeters of topical application. There was kind of an observable, measurable difference. But importantly, this was not only for just a topical agent just in general, but also the silver sulfa, I can never say this, silver sulfa, we'll just go with that, silvadine. Silvadine, sponsor me. So with those sorts of agents, because that's another part of this too. Is not only is there a bolus effect of these topical agents, but also even worse is the dreaded silvadine. Because certainly, if topical agents are bad, then topical agents with metal in them are even worse. But this was a very beautifully crafted paper using gamma H2AX foci and tunnel staining and all these things, in addition to the dosimetric measurements, basically showing that as long as you have a normal application of topical agents, there is absolutely no clinical sort of effect on the surface using modern radiotherapy techniques. And then this was a few years before, there was another paper that came out called Dosimetric Impacts on Skin Toxicity for Patients Using Topical Agents and Dressings During Radiotherapy. And this was June of 2016. So I hadn't even considered this angle of it, but this paper took 17 different topical agents and dressing and did a bunch of dosimetric analysis with 6 MV photon beams with a 100 centimeter SSD. So they compared it to an Aquaplast mask, or they called it a thermoplast mask. So again, Aquaplast, sponsor me. But so I never considered this angle of it, where the same people who are concerned about topical agents of lotions, creams, and whatnot probably use thermoplastic masks without hesitation, right? So from this 2016 paper, the relative skin dose under the reference material, so compared to nothing, it was 128% under the thermoplastic mask, 158% under 5 millimeters of bolus, and 171% under 10 millimeters of bolus. So they had a quote unquote realistic application of topical agents, which I think is much more reasonable at 0.5 millimeters. That seems like a very realistic size of bolus or lotion. The relative skin doses were only 106 to 111%. So, which is what, I don't know about you guys, but I often ask for global hotspots of 110% and below. So the thermoplastic mask, the Aquaplast mask, produced a measurable 128% increase in skin dose, whereas a normal application of lotion was 106 to 111%. So I think that's pretty important, where people really need to kind of examine their own beliefs and cognitive dissonance. For if you're okay with using an Aquaplast mask, but you have told patients to not use Aquaphor before treatment, or certainly, or have held off on prescribing Silvadene because of concerns over dosimetric effects. I think that is something it's really worth taking a look at this paper and kind of thinking about if you agree with the conclusions, and if this is kind of can apply to how you counsel your staff, yourself, and residents and patients and everyone involved. So I feel like in general, we have really pushed this off to the side, and we don't have great sort of recommendations or guidelines for skincare. Sometimes I feel like it's not just radiation medicine, obviously. I feel like in most medicines that people like to jump from one sexy item to the next sexy item, because those are things that get you grants and plenary sessions and whatnot. And the unsexy things are, kind of the nuts and bolts sort of boring stuff gets left in behind. And sometimes it feels like we invent a car, but then we forget to put the seats in it. And this is one of those things. So we will cure your cancer, but we might cause a lot of side effects and long-term effects. We're not so good on that, but we're going to move on to curing the next type of cancer. And so I included a paper from it's a dermatology paper actually from last year, kind of talking about different ways to manage. And so for personally, what I personally do and what I recommend to people to do is I encourage gentle washing of the treated area twice a day. So we'll just say breast is the easiest one. So for all my breast patients, so I usually ask them to gently wash with gentle soap and water. And if they're kind of unsure about what that means, I usually say baby shampoo, if just to give them a product. Otherwise, my rule of thumb is something that doesn't have a strong scent. So a gentle soap is one that doesn't say has special antimicrobial things in it, or has a very strong perfume or scent. And if they really want a specific product recommendation, I usually just say a baby shampoo. So gentle washing twice a day, once in the morning, once in the evening. And then in the middle, I recommend some sort of oil-based lotion. So the old standby is Aquaphor, but Aquaphor as a petroleum jelly is very goopy. It's a very professional medical term. And so based on some other research, I actually really like calendula lotion. And so, there's not great data on any of this. There is some RCT data on a calendula lotion reducing radiation dermatitis more than other types. So I personally like to recommend calendula based lotions, especially for the breast patients who are wearing bras, shirts, those sorts of things of clothing. Having a lotion that's much more similar to other products like CeraVe or whatnot is very beneficial to them. So I use Mioderm a lot, or I say Mioderm. I don't know what the real way to pronounce it is. There's various other ways, lotions that you can recommend. So that's where I usually start, twice a day, and then with an oil-based lotion 3 times a day in between. And then if they start to have some dermatitis or some issues, I'm pretty quick to jump to, now triamcinolone. After there was a tweet about that a couple months ago. But so the data is usually using mometasone, but mometasone is a little bit more expensive and comes in a smaller tube. And triamcinolone is cheaper and comes in a big tub. I think it's like a 454 gram tub. I don't know, but it's a lot cheaper, and it's got like a 12-hour sort of half-life. So I usually, with that, will say wash once in the morning, once in the evening, and then apply the triamcinolone cream after each time. So, in the morning to kind of last throughout the whole day, and then before bed for overnight. In between, at that point, we'll say, use Mioderm or Aquaphor or whatnot in the middle. If they have continued sort of issues, I will then go to Silvadene. So I'm pretty quick with the Silvadene and have had really sort of positive results from that. And it's very obvious. I always joke, it's kind of like those of us who go to the dentist and the dentist asks, are you flossing? You say yes, and you're really not flossing. You're just lying to your dentist. It's very clear to me. I have a pretty high volume of patients who is actually doing the skincare routine and who is not. And even just something as basic as washing the skin twice a day, and even if they only sort of do what I'm asking. So even if it's just once a day and maybe twice with the lotion, there's still a pretty big difference between that and the people who don't do anything at all. And I was it's really surprising to see how much of a little sort of intervention like this makes a big impact. And the other one that I have noticed that actually a patient told me, and I just kind of pass along now, is that sometimes for specifically with the radiation dermatitis that has an itching sort of factor, so it's not always the way people perceive the symptom is sometimes different. So for anyone who has an itching sort of dermatitis, I will have them try the Benadryl cream, and I've had pretty good success with that. Obviously, I shouldn't say obviously, I don't think there's been any sort of trial evidence on that. That was sort of an empirical recommendation based on feedback that I got from a patient that I use now. So I'll have them roll that in. But so really the whole point of this was to basically just discuss that this belief that lotion or topical agent or whatever, Silvadene is causing a bolus effect in the modern era using, the modern sort of strengths of linear accelerators of radiotherapy that we have is totally unfounded and is probably doing more harm than good if that's something that's being kind of continued on. And what really jumps out to me is I had a patient that was told that, and, people really internalize the things we say, whereas we know, we being physicians or whatnot, or medical professionals, can contextualize sort of statements or read something or advice, and we won't kind of burn it into our soul, but people who don't have that sort of experience will. And so I had a patient who was told this, that he needed to make sure he had no lotion on his skin before he came in for treatment, and he came in and he had scrubbed so hard before treatment that he was bleeding from the site that we were treating. And I'll just never forget that. And it was when I asked him what was happening, why did that happen? And it was just because he thought that even the slightest amount of lotion was going to mess up his cancer treatment. And so that's why this has always been something that has really stood out to me. And then as I've seen sort of the effects of hearing about this and passing this along is kind of detrimental. So, I think for me, this issue is pretty open and shut. I still keep hearing about it, and I would really like to put this one to bed. So myths of rad-onc, myths of radiotherapy. Lotion is fine. Don't cake it on. And if you're someone who can put more than 2 millimeters thick of lotion on, I want to see it. Maybe that'd be a Guinness Book of Records sort of deal. But so if anyone has any other thoughts or comments, I would love to hear about them, and tweet at me or yell at me, just because I would like to hear if I'm wrong or not. And don't be afraid to use Silvadene, in my opinion. If anyone wants to fight me on that, we'll take it to the internet. So, all right, we'll leave it there for now. I'm going to keep doing myths of radiotherapy. There's one or two other things, but stay safe, everyone. Thanks for listening to this episode of Out of the Basement. You can claim CME for this and any other episode by following the link in the show notes. You can find me on Twitter with @DrBekta, or visit www.bektamd.com. If you like this content, please let us know by rating and following us on Spotify or Apple Podcasts. If there's any topic you want to hear covered, or if you want to come on and talk about something yourself, reach out and let us know, and we will make it happen. Otherwise, talk to you next time.